Go back to no. Did he say this? No, he said that.
And there are endless videos on in the software. There's a little what looks like a YouTube icon in the top right hand corner on all screens in Romexis. If you click on that, it takes you right to the tutorial page.
Oh, okay.
And it's there are videos that pertain to everything from placing implants to positioning to there's tons of stuff on Vimeo and YouTube. It's endless. So so are you guys capturing are you going to take everything into Romexis, or are you capturing your pans into something else?
We have Dexys.
Okay. They may have set it up.
I don't remember how he set it up. I don't really care.
Some software that was added to the computer, right?
Sure.
I'll let him figure it out. I don't know.
Romexis is what you have to capture 3D into, but it's an all-encompassing software. You could capture your 2D, your 3D, your intraoral images, your photos, your STL scans from your scanner. I mean, all that stuff can be captured in Romexis. But many people, if they start out using Dexys or Dolphin or something else, then that's what they're used to, and then you can take the 2D pan portion of this into that software, and that's probably how they set it up.
Probably. That's what I'm used to.
That's what they would have done. So.
So what that means is basically, if I'm in a hygiene room, I can still look at their pan, but I can't look. You have to get out of Dexys and go into Romexis if I'm going to bring up their 3D skull and look at it. That's a whole different.
Yeah.
deal.
So that's that new icon we saw on the tab on the chart. Okay.
It looks like a little diamond.
Yeah, right next to the
Yeah,
Dexys.
that's Romexis.
Okay.
Yep. So after you bring them, you bring up Dexys and you hit the little bubble pan man there. That's what we call him, the pan man. And then that's where you capture the pan. So you bring that up, patient's chart. They're kind of standing here, realizing this thing
We
is.
have the computer on, so it's
Yeah, just move the mouse. It should turn itself on.
Yeah.
Pamela, you want to move that oral surgery card out of the way? Just put it anywhere. Our Target oral surgery card.
So you're doing the same thing we did before to bring up the
So yeah,
patient.
that's what I just want to make sure that it's all the same.
See everything.
Is that a better one? Doing the.
Well, this is the 3D support, but you can use it for 2D and 3D.
Oh, okay.
Officially from Plan Mecca, you're supposed to swap these in and out.
Mm.
And most of your colleagues, the biggest complaint is like, do we really have to pull these in and out when we're going from 2D to 3D?
Yeah.
The unofficial answer from Doug is no.
No.
These radio translucent rods end up outside the condyle, so they don't really hinder anything you're seeing in the pan.
Great.
And then it allows you guys to keep one head support on the whole time.
So does that stay put together or do you change?
Oh, I see.
So this will stay there.
Okay.
If you call Plan Mecca, they're going to tell you that you're going to use these for pan. And if you tell them that Doug said that we don't have to, I'm totally going to deny it. But this is, you can use this. This still provides the support for, you want 5 points of contact while you're taking a pan. Keep people from moving around.
And
Why people have a bigger head?
yeah, I was going to just say.
Well, you know what? There are always people outside the normal demographic that are going to, if normally you can squeeze, you can get, I've taken some pretty big noggins, one that I didn't think would fit the chamber of an M11. He was able to squeeze his head in there and everything was okay. But they're always going to be, I always work those CDA, MOM, Mission Mercy meetings, and I pull 400-pound people out of their rascals and gotten good images with the ProMax. So it's just, I'm going to give you guys the idea of how it works with the ideal.
Okay.
I call them all the VAs. Most people come into it like this, right, already.
Yeah.
So we've got to put a chair here,
Right.
accommodate the curvature of the spine, prop their legs up, lower the machine all the way down, tilt their head in so you get somewhat of a diagnostic image.
Can I ask you a quick question? Just curious if, will it still work even with this little top piece on? Can we just take that off? Say, will this bend enough? Or do these move at all? Does it go like this?
They don't.
Oh, they don't? Oh.
These are permanently in here.
Okay.
As fixed.
Got it.
I'll be quite honest with you. I've never run in. There are some larger noggins. I just have not run into that.
All right.
And it'll be so few. You're gonna have. This thing really only goes up kind of for like a 6'3".
Oh, really? Because we have some guys bigger.
We have some that are like
You're gonna need a chair.
Yeah.
And there's going to be people that are outside the, 85% of the types that are going to require a little creative.
We have some
Like with the
kids
panties.
who are like
Okay.
6'6", or a football player, and they're they can barely fit in.
Yeah, no, I had a 20-pan deployment at Camp Pendleton 10 years ago where they brought in 40 kids that looked like they'd been working their shoulders since they were born, right?
Yeah.
So
Yeah, we got a few of
they
those.
immediately wanted to hit L and XL on each of these, but it's based on age, not necessarily size.
Okay.
So XS, you can see all those primary teeth.
Right.
Nice. That's really ages 6 to 9.
Right.
If you choose S, that's really all your adolescents, up till about 16, 17 years old.
Oh, okay.
M stands for most.
Oh,
That's
wow.
all- that's
I never
all-
knew this the
That's
whole
all of
time.
us. And if you call a different technician, this is right from, I was able to sit with a physicist in Finland, and he kind of explained to me how they design this. And he said, and from his lips to my ears, this is what he told me.
I believe you.
So, and this L you know, this is for, you know, some of your friends that maybe their ancestry brings them closer to the equator. I've got a buddy who's Samoan, and you can tell there's bone densities at work there that are going to require a little bit more juice and velocity to capture an image. I've never, ever used XL. And at Camp Pendleton,
Extra large?
yeah, the bubble setting.
Extra dense.
Yeah, extra dense.
Extra dense.
Yeah, that's right. And they, these big kids that were walking through, they were hitting L and XL, and they were burning all the images out because at 18, 19, you still got puppy bones, right? Even though you're 6'5" and look like you're, you know, benching 600 pounds. So this is kind of the.
So you're saying, so wisdom teeth would we do most, or we would do the 16?
No, you.
Always stick to most?
Yeah, no, I mean it's not. I mean, wisdom. You're getting all of this.
Right, but I mean, if they're 16 years old and we're checking for wisdom teeth.
Yeah, you're right on the cusp of using small to medium. So either way, you're okay.
Okay.
Yeah, this is all about bone density, not about the size of the person.
Correct.
Right.
Yeah, and that's age related
Correct.
or geography related.
So most likely
Okay.
you use this one or this one. You're
Yep.
Even when you use it, if they had wisdom teeth, they're still going to get them right.
That's right. It's just about
their
age.
age, their age
It's
and
not
their
about
size.
size of what you're going to capture.
Right. Okay.
So
I'm kind of looking over your shoulder.
this this feature right here, this is where all your 2D projections are. It's either here or here. They either way it gets you the same. The second one, this is your bite wing right here. Now, as we discussed before, I mean, this, you know, if I set the proper expectations, this is a great tool when you have a shallow palate or tori, or a small oral cavity where you can't get a sensor into, or they're a gagger. You can get close with an explorer, they start gagging. Then you're going to get some of the information you wouldn't necessarily be able to get otherwise. But, you know, there are, like I said, some anatomy that are going to be, the limitations of what this does with a fixed tube head is going to be, you're going to get some really good bite wings and some that you don't like so much. But this whole apparatus, and Doctor knows this because he worked with one of these before, but for lack of a better analogy, when, you know, the other machines, column comes up, the arm comes out, and the gantry spins around symmetrically around the target. This one has a shoulder, an elbow, and a wrist. So it allows it to move in such a way to acquire horizontal angles and help to open those interproximal spaces better than anything else that's out there. Does it work all the time? Absolutely not. I think probably about 80% of the time you might get good bite wings. The other 20% you need your sensors. There are people in my camp that would totally refute that and say, no, this is the end all. You don't need anything else. I don't. This right here, this interproximality, I don't know if I mentioned this to you guys. I'm married to a dentist. We actually own one of these. I'm the only Pano rep on this marble that actually owns a Pano.
Great.
So,
I was going to ask you what you did because you have a lot of terminology that, you know.
well, yeah, no, I mean, you can imagine what our household is like after we're done with Netflix, right? I mean, we're practicing scanning and we can scan. But in our practice, we use interproximal as our standard pan because it utilizes the bite wing technology to help make your pan more diagnostic. So, I mean, it's up to you guys. Do what you want.
Okay, so you're saying, that you use the interproximal
Use
for
interproximal
all
pans.
panels, for all the panels. right?
Interesting.
Okay.
Because it utilizes the same technology to help capture the bite wing when you're capturing a pan.
Where was it was the third one?
Yeah,
The
if
third
you
one.
click this,
Okay.
it's interproximal.
Okay,
Yeah.
interproximal. Okay.
Yeah, sometimes my little sausage fingers don't activate this thing up here, so I come down here.
Okay.
It's kind of like anything else. that's
Okay,
up
so
here.
it's the third one is the standard.
Yes, correct.
Okay.
Third one is the interproximal.
Feel free to like jump in front
Yeah, I
of me
think
here.
you're just going to have to like
And the-
press buttons, you know.
You don't be aggressive. Just like get out of your chair and go up and look and push people out of the way. Hello.
Orthogonal. I don't know if you guys realize how pans are captured. They capture this side, they capture this side, and they stretch it out. Hence, you got spine on both sides and condyles and the whole 9 yards. Orthogonal captures the pan a little bit differently by cutting it up into thirds. And how that avails you guys is that it helps minimize the shadow casting. What happens when you have an earring here?
Yeah.
It shows up here, here. I know. I've got 2 teenage boys. Some of their friends look like they fell down the stairs holding a tackle box, fishing. They got all this crap in the face. Take it all out to minimize the amount of artifact you get.
Yeah. Their tongue.
That, all that stuff.
Yeah.
And when you have like a barbell that they can't take out, then you can explain to doctor, well, you can't take that out. That's that artifact, and that's the way it goes. But if you have an adult patient with a bunch of inlays and onlays, those tend to wash out all the apices in the maxilla because it comes from an angle down here and it shines up like this. This and this, that's not going to have any effect on your oral cavity. But everything here needs to. I had a lady with hair extensions. A lot of starring, and we couldn't figure out why there was so much scattering.
You know what? On the phone, when we know they're going to get a CT, we should mention that to them. Just tell them to leave all your piercings at home.
You can't really
At least all the piercings,
see.
yeah.
Or can you just say, as much as you can, different piercings reflect off the scan, and it makes it a little bit harder. If there are some you can take out, that'd be great.
Yeah, we usually have them put them in like a cup when they get here, like have them take all their.
Yeah, before we take the pan.
Piercings, people don't want to take them out and leave them home because they're afraid the hole will close.
Yeah,
up.
people
I'm not
are
saying
weird
that
about their
from
piercings.
experience.
That's why.
Yeah,
All right.
I'd rather just take them out as.
All right.
Yeah.
And you really, and everything I'm seeing for 2D, you're going to mimic stance-wise and your protocol for 2D and 3D, so you're not thinking, oh no, this is 3D, what am I doing different? No, it's all going to be the same for you guys. So just, another thing that I like to point out on this screen, okay, so we're good with all of these guys here. Again, back to the old CDA CARES meetings, where we take 530 pans, including pre-screening in 2.5 days. It's crazy. And right next to us is this PA department, where they have nomads and who's ever sponsoring the sensors. There's always like 10 rows, 20 deep, and people standing around. Every once in a while, one of your colleagues will come over and say, hey, could I capture a maxillary posterior PA real quick with a ProMax so I can get this person on to the next station?
Oh,
So now, with the another thing that we do that's unique to Planmeca, instead of a piece of metal where they punch a rectangle out, and the particle accelerator, as it's pushing the radiation out, it narrows it down to that little rectangle through the target end of the sensor. We use a four-bladed leaf spring collimator that allows us to isolate very easily. I'm just getting radiation right here now. So, and
that's cool.
the reason I use this is because as a patient, this is my favorite PA to get, right? You guys all agree? This, when you're trying to, suppress your gag reflex and it's cutting into the back of the roof, it's, and as an operator, you hate to see the patient wince like that. This is just another way. You'd be surprised at all the anatomy and what you get when you do this. How about elongation in the anteriors? This is just another way to get up. If the sensor's not working for the patient or for you, know that you have another tool.
And you didn't have to touch anything to do that. You just touched the screen.
These little circles right here allow me to either turn the radiation on or turn it off.
Okay.
That would be
So
great
you're
for
under
young
standard
kids to find out if they
Oh,
have,
it's
like,
there.
a
Okay.
novice
Yeah.
or whatever.
Oh, I see. So you go How standard cool is and then that? select
Okay.
each area.
So
Oh, that's cool.
just another way to get places that you may
Well,
not be
that's
able to reach.
really not-
Yeah.
But yeah, that is, don't get rid of your sensors. Use all the tools you get.
And does that take? So when I'm doing that, does it take the bite wing only, or does it take what? I mean, how much does it take of?
This right here, you're not. This is
This
an
is
extra
only the
white
bite
wing.
wing. Okay,
Correct.
but when I'm doing just this, is it actually taking a PA of the top
right.
and a PA of the bottom?
It's just whatever you block out.
Whatever I block. Okay.
Whatever's
So you
showing
can
is what
you
you're
can
gonna get.
Okay.
you can do this right here.
Oh, okay. So I see. I can go all the way around. Oh.
So now you're
Yes,
gonna
I-
get.
that's all you're
so
gonna
and I'm just okay. Okay.
Now I just I caution you guys that this is a generic smile.
Right.
So that might not get exactly what you're seeing in this generic smile on any given patient's anatomy. So I
need to go wider.
always would go bigger than smaller
Okay.
to make sure you get all the anatomy you need.
Yeah. Okay. Open up the window a little bit there.
But I think that's a really underused tool that we offer.
Mhm.
Because when I come back in 3 weeks and we kind of do a quick review, which is what I normally do, and I'll say, so how's this working? And you guys, oh, I forgot that was even there. It's sometimes it just kind of
Right.
goes past. So once you're these buttons over here, again, the rule being the least amount of time you have the patient standing here, the better off you are. But let's say you have somebody who's super anxious to be here to get in the first place, or you have maybe a special needs person, and this will actually garage this and bring it out of the way.
And that's what I
So
was
they're
wondering
not-
how I got that patient through that.
So they're not as.
So that was on the waiting mode.
I'm sorry?
What mode? That was on. How did you get there?
That was it blocked?
No, it's okay. We're good.
That was
So
there.
this-
Right there.
correct,
Okay.
correct.
Yeah.
I'm sorry,
Upper
which
right
one?
button.
And these right here.
Uh-huh.
This just shows it pulled out of the way.
Right. And then that.
Is that gonna be okay?
Well, we all know how to need to correct for that.
It's just goes in my call to Eric when I get
Okay.
when I leave.
The call Eric file.
Yeah, that's all right. So
Although Eric did come.
okay,
He did measure this himself.
okay, good, perfect. I'm still calling him.
Okay.
We're just gonna chat about the buttons and
Okay.
stuff. So again, the same thing you guys did for pans before, you'll do now. And what you hear from me, it might resonate with you. You might, if I know all this, this is all remedial. So sorry about that. What I generally like to impart to anybody is that we still want 5 degrees down in this occlusal plane, centered in the machine, and this light right here needs to be between 10 and 11 on everybody. Man, I'm a child, big little
Smile
smile.
ones, yeah.
That's right. So this, for years and years, was always paint the cuspid. The ProMax gets the best image if you can actually get that layer light between 10 and 11. This little
Right.
wheel right here will help you adjust that.
Okay.
Wait, is it? I'm sorry, this one?
It's this one right here.
Oh.
Okay.
So
All right.
when the patient first gets in here,
He had the little plastic.
ta-da!
And then
And
When you're standing from a 90-degree angle,
I have them smile. Yeah, and then I
And then
just
it's, oh, I see. Then you move
and then I can move it back and forth.
Right.
Okay.
Okay, so just like the pan.
You can take your own.
You can take your own. Yeah.
Yeah. Okay.
ta-da.
Good to
So
know.
same lineup like the piano. That makes
Okay.
it easier.
Okay.
Now, if you're from where you were looking at me, can you see that my profile is flat? That my chin and my forehead, not one is in front of the other, but it's completely flat, right?
Right. Right.
That the safe money is that my occlusal plane is on a 5-degree down angle.
Right.
This thing right here, the Frankfurt plane light that runs through this infraorbital notch in the
Right.
top or middle of the tragus, if this goes out, no big deal. Your
Okay.
pan's not down. This is what guarantees that my occlusal plane is on a 5-degree down angle. All I'm doing here is validating what my eyes are already telling me to be true.
Right.
So this is the key here. We don't put people in water ski position anymore. That's how I learned actually.
Okay. Oh,
we
really?
just
Yeah.
we just want weight on the heels because we still want the back going like this and the neck going like this. Anybody ever see that 10-lane white highway that washes out all your interiors? It goes right through the middle.
Yeah.
That's this.
Right. Yeah. Because they're trying
This.
to adjust for the
You're gonna hang everybody.
right.
I hate to use that terminology, but you are.
You know. Yeah.
You're gonna. I mean, you just gotta stretch everybody out,
Well, that's
and
what I
that
did.
minimizes that shadow that goes through the center of your.
So you're saying they're better off with their chin up
Right. It's better to
than looking down?
Actually, no. They need to be flat.
Okay.
I mean, but you want to.
If as your mandible becomes more parallel to the floor, your smile starts to flatten out and eventually look like a squashed kidney bean. That thin white line, which is the hard palate, becomes a thick white band as it tilts. You're promoting compact C-spine now because you're compressing this, and your posteriors become big and distended. Your anteriors become mousy. You start to wreck the image on a number of levels.
So put the bite thing in there. These are all, I can run them through the sternum, everything. What can I run
The
them
gray
through?
stuff can go in the sternum or the autoclave. This will turn into soup.
Okay, that's what I
Don't
want
autoclave
to do. Okay.
this stuff.
Okay, but all the gray stuff can go through the sternum or autoclave.
Anybody old enough here to remember shrinky dinks?
Yes.
Yeah, you know this looks like a shrinky dink if you autoclave.
Right, okay.
It
the
shrivels and warps.
put it on.
Okay.
So we write down that blue one and autoclave.
And
Yeah.
any gray can go, they can go through the sternum.
Yeah, I mean that's the biggest complaint is that the first patient of the day has a lot of foundation, and that's what.
Oh yeah, I know. Yeah.
It ends up on here, and so
Right.
you know even maybe a little piece of tape or something is always
So
good.
when we're cleaning up all of our rooms at the end of the day, double check that, make sure there's some makeup on
Just
there.
any kind of
Well,
area,
it's gonna be taken off.
Can we use this
After
sleeve
the
over?
operation.
so you're not white, and you don't have to.
No,
just
because they
in
might
case
go
you
there
have
and
to-
touch it.
Oh, okay, so we'll just wipe it off of the bottom.
Yeah. Okay.
Yeah, we have a little
Yeah. Yeah.
Do you have like little plastic barriers to go over this, or does it matter?
Yeah, you know what? Depending on what your aseptic sensibilities are these days, if you want to tear this pouch open every time a patient comes up, so they know, it's sterile.
Yeah,
you can
that's
do
right.
that.
Yeah,
But
yeah.
most offices just use a sleeve, depending on the flow of the office and how many patients.
Okay.
Do we need to buy those, or did they come in the box?
We don't make them.
You put like what the green little thing that like the green
Okay.
little condom that we
Little
use.
finger dots, all of those
exactly.
things work.
Yeah,
All
yeah.
those things
Okay.
work.
Yeah.
So,
We have those for the sensors.
so before you put the patient in, you're going to hit the 2 heads button.
2 heads.
2 heads.
Is there something that needs to be lined up with their ear, like the center of their ear? Or no.
That's this line right here, light right here.
Okay.
But that's only after you see from 90 degrees that the patient has a flat profile.
Okay.
And then you can validate what your eyes are telling you to be true by lining this line up with the, this notch in your orbit to the top of the tragus there. This little, that guy. All right, so once they're here, that's when you bring them in, you line them up, everything is good. I'm just going to take a chance that the guys in Finland didn't lick this.
So you do have to lean back a little.
Well, see, I usually have them hold the thing, and then I put my foot as an area,
Yep.
and until they touch my foot, then that's what I do.
Perfect.
Yeah.
And
That's water
from
ski
here,
position. You said
No,
not to do that.
no, that's not water ski position. That's just making sure that they're
if
straight.
they let go and fall down, they're too far forward.
Right.
Okay.
But they should be still like this,
Right.
where there's a little bend going this
Yeah.
way. If you see my shoulders, if you have a big broad person in here, if I cross my hands, it
Oh.
brings my shoulders forward and down naturally.
Oh, okay.
So this works with big broad people,
Right.
Yeah.
a smaller neck spans. This really
Oh yeah, we did have trouble sometimes with
That's
this
a
thing
good
clipping
idea.
down
Well,
on the
yeah, what
shoulders.
happens? What happens is
Yeah,
well, that's what I do
banana
because it'll rub. And well, no, it caught more was that damn shield than it
Yeah.
did there.
This is a pretty big expanse, bigger than most.
Okay.
But you're going to have people that are broad. That,
Right.
you just want to make sure this clear shoulder and C-spine as they're here. So if they're here,
Right.
and you think that it's not going to go,
This time cross there, and it drops it
That's
down.
but if you put
Yeah.
somebody with
All the
a
bunches.
smaller
All the-
frame in there and they cross, it'll make them hunch.
Right.
So save that for the bigger, broader folk.
Is there any adjustments made around their head? Because I know with the flappers you can pull them in. Got it.
Yeah, that tightens it.
Ta-da. This right here is just to make sure that they're centered in the machine.
Where did you take
That toggle button that you just
When the lights,
Oh, that's
these lasers have
Twist,
like a
twist.
75-year half-life. I don't know why they're so worried about them burning out because they never will. But after about 25, 30 seconds, they time out.
Right.
And if you hit any of these buttons, they'll turn back on again. This is just, you'll never hit anybody's median, but some of your elderly folk will look at you like this, and in their mind, their head is straight.
Right.
But you just want to make sure that they're straight in the machine, because if you have one side that's big and distended and open interproximal space, the other side looks like it's smashed together with mayonnaise smeared over it, it's because the sensor's passing closer to one side than the other.
See, and that's my concern. Because see, before the way the panel was, I can go to the front and I can see how they look. Now I have to kind of go to
Yep.
see. You're perfectly.
Yes.
Yeah. Because some of the elderly people, I keep an eye on. Okay, now.
You just want to
yeah.
palpate their head, make sure
Right.
they're straight in the machine.
Yeah. See, but now I'm doing that at an angle, so it's like how do I? Yeah.
These two lights are just guides. This light right here actually determines in what proximity the sensor is going to pass in front of your oral cavity. So if this line is not between 10 and 11, if it's too far forward, you're going to get little mousy anteriors in front and a whole lot of spine. If it's too far back, you're going to get big buck teeth in front and no spine. And it's it's just it's critical that this is between 10 and 11. If you have that patient where you ask them to smile and they kind of like glove up and lift their lips, you can actually see that. Super important.
So what are you making sure is between 10 and 11?
The light.
This one right here.
The vertical.
You know how the light here and the light there?
vertical.
Yeah.
This one right here is the one that you need to be between 10 and 11. And then the usual stuff ensues. You know, the tongue in the roof of the mouth, swallow, breathe through your nose. Air always has had a detrimental effect to radiography.
Right.
So if you have a dark splotch here, it's not because you messed up on the quadrant and the density, it's because they breathe around the bite stick during the exposure.
Right.
If you have a big dark band all the way through, it's because they're breathing as it goes.
No
It should be dark around the septum, and there should be a thin dark line because the airway is still open. It just doesn't intrude on what you're trying to see.
I have a quick question about the apron. Did you say, let's say we get a big person and it's clipping on the apron as it's going around. You're saying technically you don't really need the apron?
As we all can talk about, no.
Okay. All right.
But
So
it's-
in a pinch, you can just take it off.
That's right.
Got it. All right.
In fact, they should. I mean, you know, usually the issues that I see are, you know, where they didn't make the kid take his hoodie off.
Oh, yeah.
Or
the hoodie.
you know,
The hoodie
there's
is
just-
another thing.
This guy's finally retired, but I used to have an argument. Now with the technology we have, this fixes this. But he would argue with me that every time he had a woman with big hair in the machine, like a bun or something, that somehow it would impede this moving around and mess up the scan. This thing pushes like 75 pounds. Big hair is not going to keep this from going around. But if I come up behind any of you and swap your ponytail, you're going to move because it's just a natural
Right.
human
And
reaction.
that's what the
That's what
ponytails
happens
do. Yeah.
when you
Okay.
have articles of
clip in
clothing,
their
big
hair or
hair,
something.
things that it's just.
So what do you tell them to take their
I
hair
take
down?
them. I make them take the clip
No,
over
actually,
there.
we'll get to the technology.
I make them lower their ponytail.
I mean, if they have a beehive, I mean, you could just pop this off.
Yeah.
Just pop that whole thing off.
Beehive.
A B-52 or whatever.
What's the Southern Belle lady?
Mary Johnson. She always has her little
Yeah, you
buns.
make her take hers out. She would hate that.
Oh, God. Oh, yeah, not Mary.
Any questions on the 2D part of this?
Mm-mm.
So, you know, since you guys have all taken pans before, nothing's going to change. It's just the nuances of how to operate this.
Okay.
And they've made this over the years look more and more like this. We're all pretty good with these, right? So
Right.
this,
No.
they just make it well, yeah. No.
You're right. Robin,
Oh, yeah.
Robin, let's see who's coming in.
Thanks, Father. So this is just, what is this? Is this just, you were just showing us this, or do this come up, do we have this up every time we take the Pano?
This comes up every time you take the pan out. Then
Okay.
when you're done, you're going to either hit the radiation button or the play button.
Okay.
Right.
Okay.
I will save, there's another feature here, it's called autofocus. I will save this for another time.
Okay.
This actually, the perfect pan would be if you could line up the apices of 9 and 24 on everybody. And the only way to see that is to rip somebody's face off and actually, so you can't do that. So this little red light, it takes a little scout shot, and it's about this wide, and it shows you where the apices of 9 and 24 are on every patient.
Oh, nice.
And then you can adjust the red line, which adjusts the unit to the patient, not the patient to the unit. However, everything we just discussed, the 5 degrees down, straight in the machine between 10 and 11, if you can nail that, then you've got it.
Right.
And usually, if you can't nail that, and I come back and I show you 3 more steps on how to use autofocus, I mean, your eyes are rolling back double pineapples. You're lost from the first 3 steps. So I tend not to overload you with that kind of stuff. And I'll email you there's a quick little cheat sheet on how to use that. Okay. But it's so that's
All
2D.
this is going to go out of my head right now because
It's-
I'm not feeling well.
I'll send you the
I have
video.
a headache and everything else, and I'm just sitting.
I know. I'm proud of you. I'm proud of you for being here. I'm proud of you for being here.
I wish I had a little blue, I had like a blue or red pill to give you. And he's like, oh, yeah.
I'll send you a link to this.
I think really it's just gonna. Me, I'm kind of more of a hands-on
Yeah,
learner.
yeah.
Like I'm listening to everything you're saying, but it's gonna take me just doing
Absolutely.
it and
I
figuring
know.
it out. Push the buttons.
Sorry.
Oh,
New sheets. Everything that I've said
oh, good.
is on this sheet.
Awesome.
It's laminated. If you get schmutz on it, you can sponge it off. All good.
Don't move it. Don't move it.
And there's 3D as
Taking a
well.
picture of it. Hold on.
Smooch on it. Okay.
Smart
All right.
pan.
Yep.
Smart pan.
Oh, that's great.
Yeah.
So, and here's that little list of things we were for radiation.
Okay.
Here's a little list of what you can compare. The pan to and how much radiation.
Okay,
So,
right.
if the patient needs to see that, you got that.
Right.
Here. This is another quick guide that they included. Again, very Dr. Seuss-esque, lots of pictures, rhyming words. All good. Sorry.
Oh yeah, sure. Okay, got it.
Ta-da. All right.
Okay.
All right. So, are we ready to go to 3D?
So that was TD.
That was 2D.
When do we learn Romexis?
We're gonna do that right now.
Okay. All right.
What button brings it up and down for me?
So have Robin make it.
Okay.
Have her make you a copy. I thought you brought a copy in here.
There's tea.
It's all you.
Oh.
Okay, and these, what's the difference
Between the
Yep.
TD and the
These.
This actually
2D is a piano. 3D is
These are not
the
active.
full-
This is
okay.
a plus.
full skull.
This is this actually raises this up a little bit.
Yeah.
But
So
that's- but
these are the only buttons.
That's right.
Okay.
Don't worry about any of it.
You need the 3D.
Well, I mean, I need a 3D. Yeah, because I have to measure the length, width, and the height
Okay. So
in order to pick the right implant for
Got
your
it.
spot.
So everybody see this little icon right here?
The R.
This is the R in a kind of a blue and red
Oh
diamond.
yeah.
There it is.
All right. Ta-da. Here we go. So eventually,
You can probably stand back here and see it even better.
you guys
For
are
people who want to
you
get
guys are using Dentrix?
Yes.
Perfect. So, and I think I would imagine they, let me see, did they? Yes. So I would imagine they, what you'll do, if they link the two, is you'll be on your schedule, and then you'll choose the patient. The patient chart will come up, and then there'll be a little Romexis icon in that chart.
Let's try that.
How easy is that?
Yes.
So I can just go to my chart. I don't have to go. See, when we had to go in the panel, we used to have to go into the Dentrix. So I can just
So
go
now
into
we
the
should that.
schedule.
Yeah, go on the
Okay.
schedule.
So
I'm
I'm
gonna
gonna
pull
do
up the
it.
chart. Look for the symbol.
Is it the bottom of there? Smart image?
Let's go to.
Oh, that's what
Ah, there it is right there.
Oh, right there.
It is right there.
Let me see what it looks like.
Little R.
Little R.
That's the top.
So you
Okay.
click on launch on
What?
There was a
Coffee instead of coffee. That's
And
what
then-
Pano made her coffee.
Oh.
That's okay. Just hit
Jeez.
okay.
Is it okay?
Yeah, you should okay.
all need
Okay.
All right.
And then I'd go to.
For coffee.
So, did you? So we pulled up Romexis in. Let me see here. Okay. What we're gonna do is go to File.
Okay, file.
I hope things are loaded right.
It's okay. It would be total par for the course if something needs to be adjusted. That's not a
Someone's gonna have to show us this.
Moses. We had Moses come over.
Moses.
Oh, okay.
Yes, he called me.
Just a two chart.
Okay.
Just a minute.
You guys are gonna have to show us this. I think our patients are waiting right now.
Yeah.
All right. I'll show you the video later.
Okay, good.
Thank you.
What does TDAPI mean?
ADAPI is just the way the unit is talking to the software.
Because
So-
I did see some windows pop up saying something about the older version of TDAPI needs the newer version.
Okay.
I took a picture of it with my phone.
I see up there too now, next to image, smart image, so that must be this. If you take one, it probably shows up under smart image.
That's okay. Let me see. Ah.
Same one.
Your arm hurts? Really?
I couldn't even look at the
Gosh, I didn't feel anything.
I couldn't sleep. I couldn't sleep last night because every time I go to move, it'd be like,
Mhm.
and then I had a fever. Yeah, it was just.
Yeah.
Oh no.
Say 24, 48 hours it hits it.
I'm like, no.
Yay.
Okay.
Yay.
Okay.
Oh, good.
So what do we? So
It's gonna work.
We wouldn't have to go through all that, right? We would just go to the
No,
patient,
it's just
the R.
a little thing that Moses missed when he said it.
Okay,
I
okay.
know how to fix that kind
Okay,
of stuff.
so now this is this what this. So when we would press R, this where it would take us to.
That's right.
Okay,
That's
so it
right.
takes us
It's
there.
gonna,
Okay.
No, I'll show you. Just a
Start
minute.
over.
Let's yes, I want to cancel. Okay. So when you press R, it's going to take you to here.
To there. Okay.
And notice how your patient's name is right here.
Okay. Right.
It's already there. We've already opened it here.
Okay.
So if the patient's name is here, you're going to just come over to 3D.
3D. You want to
Right?
3D. Okay.
And click 3D. But instead, we're going to go back to her. I understand.
So you went into the schedule, clicked on the patient, hit the R, and it brings you to this.
Mhm.
What was that little window that popped up?
Because it's already open.
Oh, okay.
So I'm just going to.
Take her out one. Okay, she's up there more than once. Or just-
No, it's just a different.
Okay.
Module to user group restriction. Okay, it's because I'm in Dentrix. So if I come here, and I go here. Sorry, this is Dentrix is a little out of my wheelhouse.
Oh, then the R
Okay,
is
there.
There you
there.
go. And then that will bring this
Right
up.
here. So,
Ta-da.
okay, are they able to change?
And we're already
Then
there,
you hit
so you're just
3D.
gonna hit 3D.
Uh-huh. So where do you see the patient's name? Oh,
See right here?
over there. Okay.
That's the files open.
Uh-huh.
So from here, see where this is capture right here? You're just gonna hit capture. Now, once we click this button on the first patient, you will never have to click it again.
Okay.
It's a noise reduction filter. It'll always be clicked. It defaults to that.
Okay. So every time once we've
No,
opened it for the day.
No,
Now forever.
Now and forever. Once you
Okay.
take your first image, now it will be unclicked the next time you open it. But when you take your first volume, you want to click it, and then it'll always be clicked.
Okay.
Okay. One thing that you can't set a default for is this is your artifact removal algorithm, or ARA. When you take 3D, it instead of an earring that comes up over here, 3D is a little different. When it hits metal, So that radiation hits metal and it creates what looks like your Kills primer that you splash on the wall. That's what it does to the image. So what this does is it reduces or removes. I don't believe in removal, but it reduces it dramatically so that it doesn't impede what Doc's trying to see. So scatter. So most of us as adults have enough restorative material to warrant either mid or high.
Like amalgams create scatter.
Amalgams got a
Gold crowns.
existing implants. I mean, all that stuff. Somebody comes in with braces. I mean,
What about just a composite?
No, it has to be metal.
metal is that.
So do you recommend mild all the time?
I recommend mid or high on every
Mid
dose.
or high. I meant mid, yeah.
For
Mid or
all
high.
adults?
Okay.
For all adults.
Okay.
If you have a child in here that has no restorative material, low is just perfectly fine because this has other properties to reduce noise other than just metals.
Okay.
So it's the guys that send the best volumes from around the country tell all their offices to put it on high every time.
Okay.
The trade-off is there's a slightly longer processing time. Anytime you process the image, it adds time. So if you don't do any processing, you're looking at maybe 45 to 60 seconds. If you do a lot of processing, it could take up to 2 minutes.
Okay.
When I first started doing this, when 3D hit the market in 2002 or in 2000 to 2006, it took 10 minutes to reconstruct an 8x8 volume. And I mean, not only is she a dentist, but my wife is German. She doesn't want it now; she wants it 5 seconds ago. And 10 minutes, 10 minutes of watching it process is like watching grass grow or water boil or paint dry. It's just forever. So, but there are some people now with 2 minutes. It just takes so long. So it's really
That's me.
Yeah, it's really. But the more you add your different, your calm and your ULD, the more you process it, the longer it's gonna add some seconds on the processing time. So once you're here, ta-da, now you can walk over to the machine and set the machine up for whatever you're trying to get.
I put it on 5 rings. I was messing
Oh
with
yeah,
it.
no worries. Mess around.
Yeah.
Your home screen is basically all the stuff that you take on a regular basis. Your 2D are going to give you your 2D projections. TMJ and sinus kind of fall out because with 3D now you're getting way more information. So if you have a patient TMD, you want to see those joints, your jaw projection is going to be the best on 3D. You're going to get all the information way more than you get from that. Here's your 2D, here's your 3D. So you're getting all the information from every angle. 3D, here are all the 3D projections that you have here: tooth, teeth, and jaw. I tend to initially want you guys to take teeth and jaw. As the years have gone by, in fact, I never ever have anybody call me and say, I'm getting too much anatomy. But I get plenty of calls. I'm not getting enough. So initially, before we get good at targeting, and endodontists have changed too. Before they're like, I got a 3x5. Can I make that any smaller? No, you can't make it any smaller. It's 3 centimeters by 5 centimeters. You're going to get a couple of units here instead of just 1 tooth. However, as time goes by, now endodontists see the value of getting opposing dentation, adjacent dentation. Why did that tooth fail? I want to get more anatomy around that area. So they're taking 2 arches when they're just trying to see number 14.
Can I ask you a quick question?
Yeah.
In Massachusetts, a place I've worked installed a cone beam. It wasn't a high mecca, but they said that for every if you take a full mouth, you have to send it to something to have it evaluated for pathology. Because you're now medically responsible. The dentist is medically responsible for cancer or tumors or whatever.
Because you saw it?
Or because you had a diagnostic image of it. That now you're in charge of their cancer.
Are you familiar with Art Curley?
No.
He's a dentist here on the West Coast. I mean, he's a lawyer on the West Coast for dentists.
Okay.
And I've heard him speak at the different meetings, and when he talks, he says the precedent is if you learned about it in school, then you're responsible for it. If you didn't learn about it in school, then it's, as a doctor, you have kind of that obligation to go, because you're going to find plaque in the carotids on a lot of pans that you take. And if you want to tell the
bean readers, you ever heard of bean readers?
My spouse sends all of her scans to bean readers.
Oh, really?
And David Hatcher and Frankie Rasso, they're the guys that actually read her scans. And the benefit of that is, it takes you out of the onus loop, but it also, for her, she took it, you guys take it for a certain diagnostic reason, but they're going to find 6 other things that during your review of findings, you're going to have to sit with the patient and go, we took it, because we're going to place an implant here, but man, there's these lesions here, and I got something going on over here, so it's got that benefit to it as well. And it's
but they charge like $150
no,
something.
she pays like $60 a
60?
report. It's a full report. And it's just something that she builds into it.
Well, the bummer is we wanted to do this for free.
Yeah.
I don't.
Well, no, I mean, this is totally up to you. It's not.
That's am I legally required to send things to beam readers?
No.
Okay, good. In Massachusetts, you are.
Yeah, not here. The deal is here is that I think the only precedent is that if you are placing an implant, you didn't take a 3D scan, then if something goes wrong, then
What the rule is there is if you take a full mouth upper and lower arch, you're obligated.
Okay.
If you take a half arch, you're not obligated.
Oh, really?
Yeah, I've not heard about that being the case here, but
Okay.
Yeah,
Anyway.
I mean, and there are plenty of radiologists here in Southern California. You don't have to send beam readers. You could find somebody here that does it for dirt cheap. You know, it's
Right.
just it's.
Okay.
She Francisco Arasso, she met years ago, and so that's why she wanted to send the beam readers to help him. It's not they're no better than anybody
Right.
else.
Okay.
So, if you guys can see this right here, this is your 8 centimeters by 8 centimeters. Generally, what I recommend is that you hit this little cylinder here, and you hit this one right here. Now, I just turned it to 10 centimeters by 10 centimeters.
Okay.
8 centimeters cuts off my thirds.
Okay.
So when I go 10 by 10, I know for sure on every patient I'm getting
I
all
like 10 by
32
10. Yeah.
all 32 teeth. I'm below the mental foramen, well into the floor of the sinus. I've got everything I
Okay.
need.
10 by 10.
Okay, 10 by 10.
So 10 by 10 is really your good implantology scheme.
A 10. A 10 out of 10.
Yes.
10 by 10. Here. Now we'll go back to what you said about the arches here. Let's keep it at 8 by 8. Let's say I just want the mandible.
Then
So
you
I'm
use
going to choose this one. You can see where my
The white?
region is. Now look, I've got a mandible here. Here's my condyles. Here's my lower arch. Here is my 5 by 8.
5 by 8.
So let's say I'm just looking at, I don't know, 29. That might be a decent shot to take.
Okay.
There's nothing wrong with taking a 10 by 10 on everybody.
Okay,
Depending on what you're looking
so,
at.
so just a
But
10.
but as you get better at targeting, then you there's nothing you can't just focus in on if you want. If I come to here, watch this. See how it raised up a little bit? Now there's a maxilla right there. You can see the condyles from the mandible, but you can't see the lower part. So I've just got the maxilla. This is this 5
And
by
that
8.
5 by 8.
a 5 by 8 is
Correct.
maxilla.
That's maxilla as well. And I just raised it up using this. And then from here, now I'm back to both.
Both.
Now you can see the maxilla is superimposed over the mandible. I'm getting both the upper and the lower.
And that's at 10 by 10.
That's right now we're 8 by 8.
You're 8 by 8.
We'll see. It shows you right there.
Okay.
80 millimeters by 80 millimeters. Sorry. It's
And that's getting.
this right here. You hit the cylinder, you hit the big cylinder. Now you're 10 by 10.
And would you recommend 10 by 10?
I'd recommend 10 by 10 starting out on everybody.
On everybody.
Okay.
What's nice about 10 by 10 is I can see wisdom teeth.
Yeah.
Right, right. That's what he's saying.
So
Thirds
10 by
wizzy.
10 just kind of opens up.
You're 10
goes
centimeters
farther
in
back.
diameter, 10 centimeters high. And there's really no arches out there that 10 centimeters you're not going to get back behind thirds.
Right. Okay.
Plus, with the 10 by 10, the problem I had with the other Climac when we had it on the lower settings, it would chop off the top of the apex of the maxillary teeth. I couldn't really see the top
If
of the
you
root.
didn't
Yeah,
use a 10
so
by
if
10.
you're
If I don't
doing
use
it-
10 by 10.
If you're doing
10
it,
by
might
10
not
you're-
see everything, right?
Once I show you the easy positioning, you're always going to get everything you need. Okay.
Okay.
So, all the same things apply here with, your M is almost for everybody. And I don't think we need to go through anything else. This right here, if it was on 8 by 8, you're not going to use this because you have jaw.
Right.
So if I had 8 by 8 and I put it over here, notice how I can just move this thing around wherever I want it to be, wherever
That's what it's gonna take.
I'm looking at. If I put it here and I hit my horizontal pairs, I'm going to take 2 scans and get both condyles in 2 scans. But I'm not going to get any of the anterior.
Yeah,
Oh, that's interesting.
So, but you really, for a plus, you're really not going to use that because you are going to,
Get it all in my 10 by 10.
well,
No, not the cutout.
actually, watch this. This is jaw.
Oh.
Now you're getting
Now I'm getting.
10 by 20.
Ah.
And what
So-
would be the purpose of that?
You're getting both condyles in the same shot in all.
Ten
Let's
Right.
say somebody came with a broken jaw on a fight at a bar, and they can't open their mouth, and I could tell that I've seen people with broken jaws way back here.
Oh, so then
Or they call it
it's
upstairs.
We have a patient who can open the
Okay,
door.
so for
Yeah.
more like the
Yeah.
TMJ joint.
TM joint.
You're
yeah,
getting
TM joint.
condyles and 20 centimeters this direction. That's the whole bucket. So it'll allow you to get everything.
So why wouldn't we just do that on everybody?
Extra radiation. You're,
Too much
you're radiating more than
For
you
no
need.
reason.
Pick what you
Yeah.
need.
And
Yeah.
keep in mind too, when you're trying to focus in on something like anything else, if you take a smaller field of view, the resolution is going to be nicer at normal resolution when you have that small region of interest, as opposed to taking the whole thing. But I really only wanted to see 7.
Right.
So now that it kind of obscures
Right. Makes
the focus of what you want to see, as opposed to if you need to see condyle to condyle, that's what you're looking for. Then this is the right scan to take. If I'm just looking for some anterior teeth, or I have 30 or 29 or something.
A root canal on one tooth.
Yeah.
Oh, by the way, we're going to do CTs for everybody who needs a root canal.
Oh, you are? Okay.
Because I could look for weird little canals
Okay,
using this.
so, and that's my other question. So you're always going to want a 10 by 10 of.
I'll tell you what I want. I'll say, give me a full lower jaw.
Okay.
Or I'll say, give me a lower right. Usually I'll ask for one jaw or the other. I'll say, give me an upper jaw. Give me a lower jaw. Or I'll say, give me both.
Okay, that's what I'm asking. Okay.
Yeah, pretty much that's it. I just,
And then it's
I
an
just ask for
endo.
upper or lower or both.
When you do an endo tooth, are you going to want it to be singled out like you showed us earlier, a section just for that area, or the whole scan?
Oh,
I
okay,
don't care.
okay, but that was with the panel. That wasn't.
Oh, wait,
with
that
the-
was a Pano. Oh, yeah, so.
So there's another question.
Yeah.
So what, like she said, what if he's just looking for the endo? Can you do half the mouth?
That little section.
This right here.
I think it's faster for you guys and easier if you do
Do the whole thing?
if you do a
I'm just curious.
if you do a smaller thing, the patient doesn't have to hold
Let me
still
see
as
that
long.
again. Right.
It
Oh,
was-
so you just went from
So,
the
yeah, even like
I'm just
endo
touching it.
118, you might
Yeah.
just to get that section.
It's just faster for you
Yeah.
because then you don't have to wait for the computer to process it.
Pretty
and
much
all
where I
that.
want it to be.
So just tap, like, so if we're doing 18, just tap the lower left, and then we'll, oh, okay, perfect.
Yeah, it's just it doesn't take as long, and the computer processes faster,
And then you'll have what you need for that.
and there's less radiation.
And you guys will have, you guys are gonna be able to take a scout shot
Yeah.
on everybody.
Yeah.
Because it takes a while for that thing to go around.
And when you're doing just this side, do I still leave it at 10 by? Would I leave
8 by 8?
8 by 8? So
8 by 8
if I'm
if it's a
if I'm
single.
only doing half the draw, it'd be 8 by 8.
That's right.
Got
You're
it.
not looking for all that dentition anyway.
Okay.
So
Got
it. Yeah, then the patients too, we let them know.
again,
Less exposure.
when we do a follow-up training, we'll talk a little bit about this. Here's tooth. See how small that is?
And so would that be for, like, if
That's
you
endo.
just wanted a root canal or
Yeah.
shot, that would be endo.
And this is your
tooth at
5
the end
by
of-
4. So we'll discuss. That's kind of another session, but we'll discuss how to position that right so that you're not, taking a scout like, oh, I missed it, and then come back position, oh, I missed it again. Yeah.
Okay.
But there's a scout shot that's about it's a fraction of a percent of a PA. You make scouts all day. It's very very little radiation, and the scout is diagnostically is chaotic. It doesn't look pretty, but it allows you, the operator, to know that I'm right on target before I actually apply the amount of radiation required to get the scan. So there's no such thing as, I'm so sorry, Mr. Jones, I was trying to get 7, I got 14, I got to dose you up again. You can avoid all of that
That's
by,
good.
by
How recent is that? Because I don't
We
think we
could
had
avoid
this.
all of
We didn't
that
have the
by
scout thing back in
Taking
2016.
scout, like a test.
Really?
You did. It's
Before you
maybe
expose
somebody at the
them.
office wasn't using it.
Oh, okay. I wasn't there for the training on that one.
The scout serves two purposes, and we've had it since the beginning in different forms. Now there are a lot of manufacturers that have a scout. Before it was kind of unique to us, but we didn't have scouts back in 2009. I think is where it began to, and that was a big problem. For teams, people would send their 3D units back because they were tired of dealing with the fact that they have to explain to the patient, I'm sorry, we had to dose you up 3 times.
No, we had to do that all the time. We had to like 3 scans sometimes.
Where is
Horrible.
that?
I'll show you.
Oh, okay.
I'll show
And
you.
they didn't even know.
So let's go back to teeth.
Okay.
And this is
10 by
we're
10.
going to go here. We're going to hit 10 by 10.
Uh-huh.
We're going to go
Okay.
here. Then you're all set up for that.
Right.
Once you go to here, this is where you're going to bring the patient. into
Oh, I see. So
position.
the white face is the one without the exposure.
This is 2D. This is 3D. 2D is a fixed. They're fixed geometries for 2D. You can't. You don't want to raise the patient up and down. With 3D, if you pull this out, it's kind of a spring. But you have the ability to move the patient up and down in the chin rest.
Does this have like a place to like store the different things, or not really? Do I have to build a shelf in here?
Yeah, there's no.
There's a little pull out or something.
Yeah.
All right.
Maybe something we can fit in the tube there, right there, in that little section.
So
Get a little table or something.
there are only 2 lights for 3D. This one right here, this one that comes out of the tube head, determines the bottom of your volume or your soup can. I'm going to call it a soup can, right? Because it's 8 by 8 or 10 by 10. It's just like a big U-Bang coffee can. There we go. They still have U-Bang coffee.
Yeah, they do.
They do.
They're in pods though now.
Oh, yeah, perfect. Nespresso U-Bang, right? So this, wherever the line is here, anything south of that, you're not going to get. So if the line is here, you're not going to get any anatomy below that. So keep in mind, I want my line to be right here when I'm getting both upper
Right
and lower.
underneath the chin.
All right. This line right here, just a quick refresher, where is that supposed to be for pans?
10.
10, 11.
Between 10 and 11? All right. For 3D, you're going to move this line so that it's right in front of the anterior dentition of 8-9. And the only way you can see that, go ahead and hit that little 90-degree button in the left corner.
This one right here?
It says 90 degrees.
Uh-huh.
Yep, hit it. All this does is bring the sensor out of the way so that you can see where that line's supposed to be.
Okay.
That's how the whole thing moves.
That's for 3D.
Now you're gonna be looking from 90 degrees, and you're gonna move this line right in front of 8-9.
Okay.
Not on it, not behind
front.
it, right in front of it.
Right in front of it.
Yeah, go ahead, use the wheel. But you want to be this.
But I
you
want
wanna
to
be
be
over
there. So
Yep.
how am I going to?
No, this right here. This
Oh, the line.
This line right here. You're gonna move it forward.
This line.
This line right here. It's coming out here, not this line right here.
Okay.
This line right
Okay,
here.
let me see. So is that it right there?
No, it's not on it.
You want to be
You're
in
on-
front,
you're
and
on
from your
8.
perspective, it's a little different than seeing it from this perspective.
Yeah.
Oh yeah, if you're over here, it's
You're on
different.
8.
You're too far back.
Yeah, you're on 8. You gotta come forward towards you.
All right.
You want to move it so it's right in front of 8-9.
See, he's saying 8-9.
In front of 8-9. Don't put it on 8 or 9, but right
Yeah,
in
you're
front.
on
Right in
8.
front of it. Okay.
So you're too far on his nose.
And don't worry about it on my face. You're just looking at it right
yeah.
in here.
Okay, say smile. Okay,
Go.
smile. Fine.
Yeah.
See, I can't tell from
Look
this
at
I
it,
side.
can,
look at it,
from
look at
behind
it
you.
from here. You can't tell from over there. You gotta be. You gotta.
Oh,
be
I can see it.
Yeah, yeah, okay.
You're like this far in front of his 8-9.
If you look from where you were standing
Uh-huh.
here, you're going to see this light right here.
Uh-huh.
This has nothing to do with it. It has to be this light being in front of
Let's
8-9.
see.
Almost there.
Right there.
A little more. I go back even a little more. That's pretty good, right there.
Ta-da.
See,
Yeah, I'll
let me
take a
see.
picture.
Okay. So I have to look like right here.
Yeah.
Right.
Because if I go like this, it
Yeah.
looks like it's okay.
Right. So
Yeah.
if you're standing there, you're going to see
Right.
this light right here, which is you don't want to. You just want this
I
light
wanna
right
see-
here
yeah.
to be right in
Right
front.
there, right there.
And it doesn't matter
There
whether
you
it's my lips or my face or anything else.
Smile. And you're saying that's right in front of it?
Come over here.
Well, you're
Yeah,
sitting in the wrong
you have to be
angle.
here. You have to look from right
To
here.
be in Nina's
You'll
spot.
see. No, even more. Right over there. See it? See that line? It's right in front of his front teeth.
Yeah.
Yeah.
Okay.
What line?
This
Okay,
one.
look. See that thing on his nostrils? See that red line on his nostrils?
Yeah.
Follow that.
hovering
Pretend.
down.
Pretend that's a line going down. It's right in front of his teeth, right?
Yeah.
That's
It goes from here to his chin. It's in front of his teeth.
But how do you
That's
know
what you
it's in
want.
front of 8 and 9? It looks like it's in front of.
There's a little
9 and
roller.
10
There's a little.
feet.
See, there's a little
You're
roller right here.
moving
He's
it.
rolling it back and
Let me
forth
see, roll it.
with his thumb. See?
See?
Oh, you want it to be right on the T.
Right in front of his
Right in front. Right in front. I mean,
Okay.
because if you leave this on 10 and 11, this is the front of your soup can. So if you leave it on 10 and 11, you get a big hole here where your anatomy is supposed to be because it moves the whole volume back.
Right.
You gotta hit the 90 again because I can't get my big noggin out of here.
You're stuck.
I didn't realize
So,
there's some practice around
If you
here.
need, let's say I'm raising the whole thing up. So you're gonna raise it up, but you're gonna lower the patient. Now go ahead and raise that. Use the arrow and raise the patient.
Yeah.
Now where's the line? This line right here.
Oh, that one?
On the middle of your chin.
Yeah, down low on
I'm
the
not
jaw.
getting any. I'm not getting any anatomy below.
Because
that
yeah,
line.
I need it down here.
yeah.
Right.
So
Because it has to be
So
under
go
your
back
jaw.
there.
No.
Oh.
Lift up
Right
that.
there.
Okay, but why would you lift up that instead of just bringing
You
it
want
back
the
down?
line
Did you
under
want
your
it?
jaw.
because you can't adjust this line, you can only adjust the patient to the line.
Right.
Oh. No matter if you go up or down.
You're just moving the whole thing up. And
Yeah, then their head's
moving
gonna go
up,
with it.
moving this where the volume is.
If you move the chin thing, their head
if you
goes
move
up.
The chin thing down. The line stays the same. It's just your now focus is smaller. It's lower.
And there's like a little button
And you
down
want
there.
it under the
So
jaw.
let me. It's a
You
little
get
spring,
everything.
right?
Yep, this right here is right here. Just pulls out. See this right here?
Uh-huh.
This right here just pulls out.
Oh, this guy. Okay.
Hold on, we're not done training
This
yet.
just pulls out. And this spring pulls out and allows
Gives
you
it
to
to
adjust that.
the
Okay.
Correct. Correct.
Is there any danger, like that somebody's gonna get their head smushed?
Oh, it's in the front of it. Okay.
No, all right.
Gotcha.
No head smushing.
Someone's gonna get their head stuck between the rails.
Yeah.
You just
I
bottom.
can do that right. I'm stuck.
This pulls this out. Okay.
Correct.
So,
So
pull this out.
exactly.
Somebody's a little pissed off at it.
It's just on, it's just on a spring. And it just there are 4 notches in there, so you
4,
can,
okay.
you can adjust it.
Yes, it's gonna do it a couple
Okay.
times. He'll get
Yeah.
it.
Yeah. So
So once you got them lined up.
once you got them good, then you're going to hit the scout button to get a scout. But let's talk about these things a little bit here. Remember I was talking about ULD?
Yeah.
This is the ultra low dose that allows you to lower the radiation and the duration of the scan without compromising what he's got to see. So here we're at 90 kV, 8 MA in 12 seconds. Ooh, we just went from 90 kV to
Oh, that's
5.6 MA in 4 seconds.
Okay.
That doesn't change the amount of time this takes to go around. It just changes the amount of time we're actually radiating the patient.
Oh, that's good.
Okay. So there are offices that use it all the time, some of the time, rarely. It's up to you guys.
So it's not going to really affect his image, what he
No.
needs to see.
The-
So maybe it's best to just use it all the time.
The noise is going to be in the soft tissue areas, not around the cortical bone and the PDLs and the things that
Okay.
you're looking at. Here's your resolution for 10 by 10. I would recommend normal, unless he says, "Hey, look, I'm looking for some pathology that I need a little tighter focus." Then HD is good too.
Okay.
However, I've been wearing these contacts for 4 years. I can totally pop them out and drive back down to San Diego totally safely. But I'm so used to seeing everything sharp that I'm spoiled. I wear my contacts every day, So if you take it at high definition all the time, and then one day you accidentally go back to norm, he's going to look at it and go, "What's wrong with that one? What you guys
There's
do?"
something wrong with that.
So
You're saying don't get
Let me ask you
all the
this:
time?
Can I still see fourth canals and a root canal
Absolutely.
with regular
That's right,
definition?
that's
right.
Absolutely. All right, that's fine.
And when I say it, I think I have this discussion at least once or twice a year. I'll have an endodontist that tells me that you can't see root fractures with 3D, even though I've shown it many examples. Now, that's just a display of what the root fracture would look like with 3D. And I'm like, well, I mean, to me, because I've got lots of examples of vertical and apical fractures, that you can see with 3D pretty clearly. But, occasionally I get somebody whose perception of that or how they talked about it in school or what have you is just different. So when somebody says, "Can I see fourth canal in normal resolution?" Well, I've got examples of that. However, it's just a matter of the better you get at navigating through. You've already been using Romexis, so you know how to get through it. But it's the better you get at navigating and how to manipulate the image, the more you'll see. I mean, there's no reason you can't find all the treatable dentistry on every patient that walks through that front door all the time. Yes.
So we have Pam here for her.
We have to do a
Should
scan for
we
implant.
bring her back?
Is it?
Do a trial on her?
But is it moving right? It's not gonna hit the wall.
No, that's a discussion I have to have with Eric
Okay.
about. I'm gonna recommend they move this over another 2 inches that way.
Oh, okay.
Because this, you have to be able to, the last part of calibration, this has to come back.
Right.
And I think he just,
Right.
So we're not going to be able to use it?
oh yeah, no, you can totally use it.
Okay.
It's totally
We're
fine.
just going to move it.
I'm concerned about that.
Okay.
And so from me to him, I'm gonna say, it's going to be recommended. And I need to talk to him about the buttons too. And there's no reason why this thing shouldn't be somewhere else where you guys aren't standing here.
Or even right here.
It'd be totally fine right there.
I think the tough part was running the wiring. They couldn't figure out how to run the wire unless they did it through the outside.
But there's a light thing. Why can't they run the wire?
Yeah, they're gonna have to tear out the wall.
Couldn't we just grab
They tried to do it without tearing out the wall.
To me, it seems like you guys have dropped ceilings here, so there's no reason why you shouldn't be able to run the wire. You know, open the ceiling and look down there. I'm sure there's a bunch of conduits around here that you can run the wire. But I didn't look at it. I don't know. I'm just.
Well, if you want it done, we can. But I'm just saying, if we got that, do we even need to worry about
I
this?
don't think you need to worry about
I'd rather not. I'd rather just. We'll never use this for anything.
That's fine.
Tape it
So we just have to just
Okay.
So as long as you're behind this wall, you're good.
So you just
Okay.
grab
But
it.
I do think you probably have a point about moving it 2 inches so it can calibrate itself.
Yeah, because you don't want to be on the other side.
Yeah,
I think
that-
it's just too tight here, and so
Oh,
that's
it is.
that's and you can move it over 2 inches, and you guys can still see this line on my chin.
Right.
Because that's important to be able to poke your head through and see that there's.
Right,
there's
right,
wires.
right.
Button,
That's
everything's
all I'm
still
concerned
good.
about on this side.
Right.
All right.
Because this no longer becomes a factor once you know that you're looking at from a 90-degree angle, a flat profile for pan. Can you
Would-
agree with that too?
Right. And I think I think patients are leery about stepping into this when it was just a panel. Now I think if it's so close to the wall, I just think it's just gonna. I think they need to feel like when they're walking and they're walking in without all the.
Yeah.
Yeah, because when I went, I just went like this. Just gonna push it out of the way. Is that wrong? Is that screwed up?
Well, no.
Did it sound good?
It's on when it's on.
Oh.
There's a band and a chain up there that gives it tension. If
Oh.
you turn it off, then this is free floating. You move it.
Oh.
Okay, so you can move it.
Does that sound good?
Hey, we learned something. Don't move it when it's on.
It will find it.
They just ruin it.
It'll home and find its
You
where it
already
needs to
broke.
be.
You already broke the new toy. Yeah, typical. Have to
These
play with
are
it.
way more resilient than they used to be. You can't.
Next
Oh,
time,
okay.
next time we're just giving them the box.
We have a patient here who needs an implant. Can we take a scan on her now?
Absolutely.
All right, let's go grab
That'd
it.
be great. I think she's getting
Yes.
it. Okay.
So that was Pam. That was one.
Did Pam was about to get, yeah. Oh, great.
Hi, Pam. Come on in. How are you? We're gonna get your scan. Nice to see you. How you
Wait,
doing?
don't mind. Does she need which news number? No.
Pam.
Yeah. I think it's number 5, isn't it? Go look at the notes.
Yeah, I'm just getting this. So it must have been for well, would it be back in
Click on that icon, and they'll drop it all down.
Yeah, but this isn't real current. But so that
I'll
was
go ask her.
So it has to be good. Oh, sure. Okay.
Was it tooth number 5?
It's only about the same. Okay.
Upper right, lower right, lower right.
In the molar area.
Yes, lower right.
Oh, okay, side number 30-ish.
Yeah. Pam, this is Dr.
Hi.
Anderson.
Hi, how are you?
Great. Welcome to our, well, you've been to the office, but yeah, welcome to the new machine.
Our new machine. This is great. Looks like it's 2, 3, and 18. Okay.
No, she said lower right.
Lower right. Well, there's other stuff too here. Teeth need treatment, 18 crown, but 2 and 3 first future implant. Oh, okay. So there's other stuff.
Oh, it says
too.
future implant lower right.
Okay.
Oh, LR.
Keep going. She's eating it. Yeah, come watch. Or come help. You get the audience today, Pam.
How you doing this morning? So we're just out of the way about where her chin's gonna be.
It's got to do have them hold it just like we were doing.
Exactly right. First, we're gonna choose key, remember? And then we're gonna rotate this and choose that. Ta-da. Now you have your 10 by 10. You see it right there. Now, once we choose this button here, it'll do this little dance. And then what you'll do is then you can invite her into the unit. Come on in. Yeah, just rest your chin right. Perfect. I like it. I'm gonna raise this up a little bit on you. In fact, we have some handlebars here for you to hold on to. Like, ta-da. Nice. I'm gonna raise this up just a little bit. And you'll see how
Yeah,
you'll want her
which is the Pam.
to still be flat.
Right?
As you were before. This is where you're gonna hit your little 90-degree button. So bring this out of the way. Smile for me, please, will you?
Like the teeth, huh? Okay.
See where that is? That's right in front of her. 8, 9. Now she can relax and. Ta-da.
That's a funny toe right there. That's a very okay.
Nope. That's gonna be okay. Don't worry, that stops when it feels resistance.
Okay.
At least it's supposed to.
Now we're scouting.
We're scouting.
We're scouting it.
Okay. You'll come over here and just make sure that this line right here is below her chin. And you can see that it is.
Yeah.
Ta-da.
Yeah.
So what we're gonna do is we're
line
gonna.
up.
So we're gonna take a quick scout before we actually take the actual X-ray, and this will show us that we're on target. We've got everything that we need here.
I'll actually show you an image.
Yes, we're gonna either click this or this. Either one will do it. And so now we can back out of the way here.
Do you recommend scouting every time?
Yes, for anything smaller than the jaw,
It's a good idea.
it's a good idea, for sure.
So I didn't see
Always scout.
All right, everybody,
Just make it.
ready? You're gonna
Yeah.
press and hold, and this is just gonna take a quick little dip. Press and hold. Yep, and then once you hear it, then you count to 3, then you release. You release now. Now for this, you come over here and just make sure that everything is good to go. Yep, I'm right on target. I got all the information that I need.
Hopefully she doesn't move between scouting and taking the real one.
That's why that's important.
So
Now
yeah,
this,
that's the non-exposure
that's
one.
it. And
Test
now
run.
there's the volume. All you're gonna do is hit either of these. Now we're gonna take the real one. Now we're gonna take the X-ray. Now the other, everything is good. So don't press button yet. Wait till when it's blinking, it's thinking. When it's solid, it's ready to roll. Okay, now you can press roll. And this is gonna pull. So feel like you're And after 10, you're just going to count to 3 and then you stop after 20. Now you can hang it. It's going to go back around before she gets out. These are from the torture chamber.
Thank you, Pam, for being our guinea pig. Our test study. Have you step out, watch your hand when you come out. See that? This one I'm concerned right here.
Yeah, we're gonna move it. We're gonna get it moved to the left.
Okay. Yeah. Just be careful when you step out.
Yeah, it's a little tight.
Perfect, you got it?
Yeah.
Oh wow, that's great.
So, once it.
Wow, there you go, Pam. There it is.
Pretty neat.
Smile, it's Halloween.
Yeah, he likes to study it.
So it's kind of, it's just changing the density?
Well, it just,
Because
this,
he wants to study it.
these up here will affect your 2D slices. So I generally use the third slider down to sharpen these up a little bit. And then these down here affect your rendering here. So the third slider down here is the threshold. There's some extra noise around here. I can eliminate that by doing this. It depends. This is so subjective. It's really this is for case presentations for the patient rather than for diagnostic reasons. There's a guy back east that always sends me the volume looks like he came from a Grateful Dead concert. He tie-dyes it all up, and it's like it's however you want to see it. But here's
So this is sliced in half?
this. In fact, I'll put my
It's X, Y, and Z plane. This way, and this way.
here are my planes of reference. So the blue one here will always be the axial slice, going up and down through the volume. The green one, the coronal slice, I always remember this coronal. I don't even like coronal, but that's how I remember the coronal slice. This runs through this way, and then of course the
Front to back.
sagittal
This way.
slice side to side.
And then this way.
So what I was talking about earlier is this right here is your magic button. This when that is highlighted, I can either left click and move this around.
What button?
This button right here, the magic button.
Okay. Magic.
This allows me to move the volume around this way. The right click allows me to rotate this way.
Oh. This is all for him.
Yes,
Yeah,
this is for me.
that's nothing to do with
Correct.
us.
But what you guys would want to, you guys want to maybe make an adjustment with making these slices a little sharper with this slider, or reducing some of the noise with this slider. That's it. That's the rest of it is going to be for him.
Right.
But when you turn this off, let's say I want to start creating a PA. I'm going to move my X and Y axis over to one side, and then I'm going to use the right mouse click to move this. Now I can start seeing stuff, and I can move this right through, and
That is so cool.
there's just
I mean, look at this right here. I just showed that perfectly.
Okay, so when I go to exit out of this to go to another patient, as I don't have to save it, everything's saved.
No, it's like Google Docs. It's always it's once you do something and you X out of it, it saved it.
Okay.
But and again, more for Doc. But if you let's say you change stuff here. I came over here and I'm kind of where my occlusion is, and then I want to come over here and just let the computer try to design a decent pan for me. So I can see bone heights and get my canals.
Wow, so you
Look at
can
that.
get into
Look at that button.
pan.
How did you sharpen it up
So
there?
that allows you to create a kind of a little pan here, and then when you move down the road to implants, then you can start, and I don't know what version of Remexis you were on before, but this is it looks a little different, but all these tools are the same.
So
Right, yeah.
let's say we took the scan and everything, and now he just wants to check a tooth, an endo tooth. Can he do the same? Can he
Yep.
focus on the one tooth
Watch
and look
this.
at that?
I'm bringing all of these red lines here represented by these slices here. No, it's okay. And so I can now come and I can now go through and find
Go to each tooth,
what
okay.
I'm looking for, and this will allow him to look through this. and see everything it needs to see. Yeah. I mean, you know, I don't know if you've ever right scan. I mean, I can, you know, take 77 postage stamps here and one off. It's
No, I usually go with like 8. Yeah, or something like that.
and then I can, you know, go down a little bit. This changes the perspective you see from this direction. This just moves them closer, further apart from each other, and it's already super thin, 0.9, 0.3. So, yeah, that's.
Very cool. Yeah, so you're telling me if this is moved over 2 inches more, it'll be easier for me to
Yeah.
walk in a paint. I just think this is kind of.
Yeah,
Yeah.
Yeah.
it's tight.
It's
It
tight.
really is.
Too tight.
Yeah,
Too tight.
it's too tight, and it just does not.
Now, is that going to change the calibration and the software? Does he have to unload or reload or do anything?
No, I'm concerned with how there's the last part of calibration requires this to be, you know, it's expanded.
Right.
And because this was brushing the wall, I mean, it obviously didn't affect what you're getting. So it's I mean, the volume is as it should be. I don't see any weirdness in that, but I just, you know, these things concern me over time.
Plus, that's tight for somebody trying to get in there.
Well, yeah, and that's a small woman.
Yeah, I mean, trust me, I've seen a lot of different installations that where, you know, it's in a hallway and you can't even get around the unit to actually, you know, set up the.
Right.
But there were limitations as to what they could do, and I see that this is a fixable thing here. That's why I'm just gonna.
Right.
I'm gonna make mention of this when I leave.
Great, thank you.
That's great.
Of course.
All right.
No.
Okay, so how do you turn the thing off?
Oh yeah.
There is. So,
There's always that.
And should that computer be shut down on the wall every night, or leave
Right over
it
here.
just leave it in sleep mode?
underneath-
I have it set to turn itself.
Let it turn
It'll
itself
turn itself off. Yeah.
Oh, right
Right there,
there.
right
So it's back there like a pen.
It's like this. If you have to raise your hand up, it's like a button going that way.
Okay, so it's
There's a
a,
button underneath here. It's green.
Yeah.
And what I recommend, and this is, you know, every IT guy has a different idea about this. There's a computer in there, and this is a computer.
Right.
And when you guys leave at night, apparently the computers talk to each other. I don't know what they're saying. Are you awake? I'm awake. I don't know. And so, but they're pinging each other. If you leave this on all the time, then this has an opportunity
To ping the
for
computer.
the registries to somewhat come unaligned and cause little glitches during your day.
Right.
If you turn it off at night, turn it on in the morning, it allows the registries to realign, so you have less of a chance of a
Okay.
IT glitch.
okay, perfect. So we'll turn it off.
Whatever is being backed up, more than likely they put the database and your licenses on your server, and that's what's being backed up every night. So that's it. You know, that's something that I would want to make sure with Shine that that's what they did.
And then,
That's a normal installation.
so we'll shut the unit off, and then if our computers go into sleep mode,
That's okay.
when you turn the unit on, it'll sync up, and
Totally fine.
you don't have to restart
Yep.
the computer. Okay.
I mean, I got offices out there that never turn this off.
Yeah.
I'm just telling you what I
yeah,
believe is
that's
probably better.
So in the meantime, this is up, right?
No, actually, it's just these two.
Oh, okay. So
Oh, okay.
until we get this moved, people are gonna have to duck under there
Yep.
to get in.
Raise it up
We'll
and-
raise it up. They just kind of sneak in there, and then we'll put it back down.
Okay.
All right.
Sounds great.
All right.
I think every office in this building has the same kind of challenge for getting 3D.
I bet.
But now, you know, for years I talked to Dr. Snyder about it. He was never going to get 3D, but now he's going to come over to you and say, "Hey, can you take a Combi point?"
right.
All right. So is that it?
For now.
Hey,
Great.
now let's do this one more time.
Okay.
We're gonna have one more scan here today.
Oh, yeah, yeah,
And you
yeah,
won't be
let's
here.
see.
Yeah, perfect.
I
And
want
you
to
won't
do
be
this
here.
one.
Okay, yeah.
Okay.
Because
Yeah, let's see. I
I'm
wanna
more
watch
of a
it.
hands-on kind
Okay,
of
so
person.
go ahead.
That's my cell phone number.
Oh, I thought you were gonna put the card in the machine.
And even though
I can just do it. It will automatically
even though my
work.
phone's been blowing up while I'm talking to you guys, I don't answer while training. So, but I will return the phone calls when I get out. But
You already have this.
But you know, if you have anytime you have a question, Doug, I forgot what you said, or what have you, call me. I'm happy to. You know, the Zoom trainings are definitely not effective.
Right, yeah.
I'm driving up to Lompoc tomorrow. I did a Zoom training for like 12 people, and in their waiting room, and it's just difficult. You need hands on to do
Right.
So,
I don't want
Just if you want to get a scan of me, you want to get a scan of me, or?
So we can tape that to the back of the
Doesn't matter
machine,
either
your
way.
cards.
I just want